The main gist of my presentation on breast cancer is that we've made enormous strides in the 20 years that I've been a consultant. So when I started, we had some chemotherapy drugs and tamoxifen, basically. There was obviously a lot of research going on in hormone receptor-positive breast cancer about aromatase inhibitors, which are now standard of care in both the early breast cancer setting and late breast cancer setting. So as with most cancers, the main drive is to try and cure the cancer if we can, or at least stop it recurring, because the question of what cure is a moot point. But it's absence of the cancer at the time that you might die of something else, I suppose, is the simplest way of looking at it. But we see with hormone receptor-positive breast cancer, there's still that ongoing risk of recurrence that goes over many years. So we're giving extended amounts of endocrine therapy. So typically, a lot of patients are now getting 10 years of endocrine therapy. Endocrine therapies are getting much more complicated. So in premenopausal women, if they are still menstruating and having ovarian function at the end of chemotherapy, because most of these patients do get chemotherapy as well, adding ovarian function suppression is beneficial, as is adding drugs that target the bones. Bisphosphonates improves the outcome. So we're adding all of these extra treatments that makes the demands on the patients and the demands on the system and the demands on the workforce much greater, without that actually having expanded over the 20 years in the service I work in, which is something we really need to think about. So fortunately for me, I've got two prescribing pharmacists. So this is, I think, important for BOPA and for the development for future, because we're not training enough oncologists, certainly not enough medical oncologists. So we need to think about smarter ways of working, and having prescribing pharmacists in the system I work in, which is something I introduced in the early 2000s, really helps with keeping patients happy and keeping the work flowing. So our pharmacists see patients as well as doing the prescribing. So it's advanced practitioner work. I think that's really important for pharmacists of the future. So they are a fundamental part of the workforce, not just in the traditional way of making sure that everything we do is safe, but also helping in the clinics. And I think that gives the pharmacists a lot of satisfaction as well. The other aspects that I think they talked about were that, particularly HER2-positive breast cancer has made enormous advances in the time that I've been practicing as a consultant. So over 20 years, we've gone from not having any HER2-directed therapy when I started. I think we were the first hospital in the country to use trastuzumab in the metastatic setting. We were very involved in the adjuvant trastuzumab trials. I implemented a service across the whole Greater Manchester system, which continues to function today, again, with the help of pharmacists with the prescribing, but also nurse practitioners who essentially run that and running it according to protocolized treatments, which enables us to, again, deliver a lot of treatment without too heavy a burden on the workforce. And I think most patients actually like that. They don't like to have to keep coming to hospital a lot, which I think sort of touches on my own personal experiences, that you don't want to be in hospital unless you really have to, and if there are other ways of delivering treatment, that's important. So the adjuvant Herceptin service actually probably is the basis of a lot of what we've developed in Greater Manchester in terms of outreach services. So I set that up in 2006. We used Healthcare at Home at the time. We switched to another third-party provider, but then we've subsequently taken that in-house. So our own teams go out and deliver those treatments in the community. That's a great benefit for patients, and again helps the streamlining of the hospital system. We've seen huge changes in new drugs coming through, obviously pertuzumab, which is standard of care now, and also movement towards these higher risk breast cancers needing to have treatment up front with drugs, because changes of treatment, depending on how you respond, is the way forward, what we call response-directed therapy. So particularly in the HER2 arena, if you don't respond to optimal therapy, we can now use trastuzumab emtansine as the adjuvant therapy. And that is the basis of a platform that I've been developing over the last 6 years in the NCRI breast group, which is for patients who have pathological complete response. We know that they do extremely well. And actually, you can probably start thinking about reducing the treatment burden and the toxicity of treatment for that group of patients. So that's the basis of the trial HER2 Radical, where we stop treatment with pertuzumab when we know there's a PCR, pathological complete response, i.e. eradication of all the cancer in the breast and the lymph nodes. And for we stop the trastuzumab at 6 months, sort of following on from the Persephone trial, which I was one of the lead investigators in. Obviously, the chief investigator was Helena Earle. And again, that trial did show that, on the whole, there's a significant proportion of patients that we, don't need to expose to as much treatment as we currently do. Of course, the adjuvant trials looked at the addition of trastuzumab to chemotherapy. So patients who are going to get chemotherapy anyway, adding trastuzumab onto that. But now we test every breast cancer for HER2 status. So we're seeing patients who we perhaps wouldn't have traditionally offered chemotherapy to being considered for chemotherapy because they're HER2 positive. And there's clearly a very significant group of patients there where 6 months is probably adequate because, we wouldn't have been offering chemotherapy. We're offering chemotherapy so that they can get Herceptin. Do they really need a year of trastuzumab? Probably not. So I think that's the direction that we're going in breast cancer. So again, it's a challenge for the system because I think everyone's very well aware that the system was built around surgery being the predominant treatment. But I personally think that actually it's the drug therapy that's the most important treatment. It's the drug therapy that eradicates the cancer that's spread around the body. We know that's the cancer that's going to kill patients. So and implementing appropriate drug therapy early and then adjusting treatment if we can, if we're not getting the right responses. That's very much the direction of travel for breast cancer. So I think the whole message of that talk really was actually we need to seriously think about where we are in terms of the breast cancer setup that we have in the UK, because is it fit for purpose for going forward into modern eras of treatment? And I don't think there's been enough thought about that, certainly in the NHS or in the government levels or even in individual trusts. So I work in probably the biggest breast unit in the UK, in South Manchester. We see 1,000 breast cancer cases a year. And that is at capacity, and, getting systemic therapies into every patient before surgery is going to be a challenge in that system. But we know that there are a lot of small units where it's even less viable because they don't have the workforce, they don't have the radiologists, they don't have the pathologists. And I think, as I've already said, going forwards, using pharmacists in a lot of roles where they can be helping out with the service, seeing patients and treating and prescribing and managing the care, I think is going to be very important for us going forwards.